I'll be gentle on Josh. I've had my children in my class at BYU. They don't want to be known. Okay, I'm Anton Bowden. I'm a professor down at BYU. My research area is in spine biomechanics and medical device design. And today I'll be talking about correlations between spinal motion, chronic low back pain, and MRI. And I'm plugging David Fullwood and Rika Mitchell, who are my collaborators on the work that we're presenting. And this is just a piece of that, but really grateful for them. David and I both invented the sensor technology that we're sharing, and so that's a disclosure. We're part of that. 3 questions to kind of start off the discussion here. First, what characteristics distinguish individuals with chronic low back pain from those who don't have chronic low back pain? And then, how does chronic low back pain change the way that we move? And can you identify folks who have chronic low back pain by the way that they move? And then third, do the features we identify in MRI data, like disc degeneration and modic changes and stenosis and facet changes, did those change the way that we move? And can we identify them by the way that people move? So, not rhetorical, like, really, what do you think? Anybody flag me as I came in and say, gosh, I can tell that guy has an L4, L5 disc that the disc height it's down to nothing, and he's lost all the hydration, lost all signal in an MRI. Had a period of chronic low back pain. You were like, yeah, I knew that.
Yes. One thing that I find fascinating about this is it's one of the most common medical problems in the world. And we don't have a great diagnostic algorithm to predict exactly who's going to have what kind of symptoms and pain. For example, you could look at 2 MRI scans and they could look the same, and they could both show problems. And one could have chronic low back pain and the other one could be up and about with no restrictions or no pain.
You're stealing my thunder, thank you.
So I think it has to be more than a single imaging modality. It's more complicated than the symptoms and the history. There is definitely a psychological component, and I think I was talking with Jen the other day. I think sometimes we end up attracting some of the patients that have pretty significant psychological problems that are manifesting. And so how do you differentiate all of this? It's not a simple answer, and it's a great, we're ready to understand how we do it.
Thanks. You guys probably know this, yes, and I'm going to share some of this data. I'm going to share just some pieces. So there's a project we've been working on, a research project down at BYU for the last almost 6 years. We're kind of taking the biocycle, the big overview of what kind of our hypothesis was 6 years ago that we're feeling really good about now. Biopsychosocial well-being, that people move differently based on those pieces. And that we can take that and get some kind of quantitative analysis through a wearable sensor system that we use. And from that, we can come up with movement phenotypes. Really the way that people move differently based on the elements of that biopsychosocial piece, and turn those into clinically relevant things like identifying what the pain generators are and what the optimal interventions might be and tracking improvements. So, refresh, this is our wearable sensor system, $8 worth of material, smartphone app in the Google Play Store, and it takes about 15 minutes. It's got 16 stretch sensors across the back that you wear, and basically tracks how the skin stretches on your back, which is related to how the vertebrae are moving. We have folks who participate go through 13 functional movements, 6 repetitions each. The whole thing takes about 15 minutes. And then this is our population. We got 306 people, 150 controls, 156 chronic low back pain folks. You can see kind of the spectrum on sex, age, education, employment, income, BMI. And so that's our folks. And so the question is, what are the characteristics that define differences between people with chronic low back pain and not? And you can see chronic low back pain duration, yeah, we expected that would be different between the controls and the chronic low back pain folks, but pain intensity, promise pain scores, the kind of the PEG score, which kind of rates overall kind of enjoyment of life, right? In terms of physical function, differences between the promise physical function and kind of the IPAC scores and the ODI disability scores, we kind of expect those. Psychosocial aspect here, we're looking at the differences between those groups in terms of depression and anxiety, sleep deprivation and pain catastrophizing. And you can see they're all different, like those groups are different as a whole. This is the imaging, and you can see the differences here, which goes back to the point that John was making just a minute ago. So what you're seeing here are modic changes. So these are the number of spinal vertebrae with a modic change in them. And you've got 0, which is no modic changes. 1, 2, 3, 4, 5. And you can see the folks in the red with chronic low back pain, there's more of them in this group than there is here. But you certainly have plenty of folks that are controls that have modic changes going on. And over here, we're looking at end plate defects, and you can see a similar pattern. In this case, the modic changes in end plate defects, there's a higher incidence rate, but definitely you can see the same features in folks who don't have chronic low back pain. These are the controls set in, yeah, I don't have any low back pain, I'm gonna be your control for this study, right? This is the MRI imaging of the discs, and you can see it's even less able to distinguish. There's virtually no difference in the incidence rates of these spinal disc-related pathologies between our healthy and our chronic low back pain folks. When we look at the facets, it's a very similar story. Virtually no differences. And you look over here in the stenosis, you think that one might be virtually identical. And these readings were done by some great trained radiologists that actually then had to correlate. There were 2 different ones, and they had to verify on that they were both getting the same answers, this comprehensive scoring system. It was blinded. They didn't know which ones were controls and which ones were chronic low back pain. And then if I look at all of them, right? So this is a little bit different because we've grouped if there's anything going on with the end plate or the modic changes at the L1 level, L2, L3, L4, L5, you see all the way across. But you can see the red with the chronic low back pain and the blue with the controlled subjects, that there is virtually no difference. In other words, if we're treating, or you're treating, because I'm a doctor, I'm a professor, right? I'm not treating anyone, hopefully. But if you're treating somebody simply based on an MRI, that might be problematic, because there's lots of folks with the same MRI who don't have pain. So 2 additional questions about movement and chronic low back pain. So if you were able, and a bunch of you are physical therapists, chiropractors, maybe experts in spotting someone. Any of the McLeans here? Oh yeah, so, I mean, Gordon, I had this issue with my neck. I was in intense pain. I was in rounds, he came in, sat down by me. I didn't say a word to him. He just walked in, grabbed my shoulder and started massaging it. Oh my goodness. He knew exactly what was wrong with me just by the way I was moving my head. He could tell that. And by the way, I don't know who else is grandpa enough to do that, but that was so good. But some of you are very good at recognizing somebody's ailment by the way they move. If you were to ask a priori, you're going to get all these folks in here, what features would you look at in the way that people move that you would guess are most closely related to pain, structural changes, psychosocial characteristics? What would those be?
They're very fear avoidant, so they don't like to bend at their hips. They could become very quad dominant, so they use their quads more to squat than like a hip hinge because they're afraid to move the spine.
Perfect. Great. Other things that you would notice?
not a question there, but how much they move.
Yeah, how far they move, range of motion, the way the kind of asymmetries in motion, right? Those kind of pieces. Anything else?
Their pace.
The rate, yeah, how fast they move, right? We were thinking along these same lines. And then which movements would you, if you had them come into your office, which movements would you have them do to kind of bring those features out, right? Talked through some of these a little bit. Well, we took those 13 movements that we talked about before, and then we pulled out, you know, we had these 16 stretch sensors along the back in different locations. From each stretch, I know this is way too much engineering here, but we pulled from each of those how far the sensor stretched, how fast it stretched. We looked at kind of the differences in kind of the time, like how rapidly it moved from one position to the other, whether it was faster going into the exercise or out of the exercise. We looked at asymmetries in kind of how each of these, sorry, got ahead of myself there, how each of these levels triggered, and then left, right, to see if there was asymmetries there. And so we got a kind of a picture. And it turned out between 8 features for each of these sensors and 16 sensors and 13 movements, and averaging over 4 repetitions, and then 15 additional secondary features for each of those 16 sensors, that we had a lot of data, like more than most of us can interpret on the fly, right? So we used an AI system to then interpret all that data using machine learning to be able to quickly take a lot of data and get it back to some form that's recognizable. I'm only sharing a piece of that today, but today we were basically looking to see those biomechanical features that we pulled out. What can we learn from them? And there's a lot going on here, but maybe the take-home message here is just based on only the way that you move. Now, this is kind of a very low bar, right? We could tell you whether you've got chronic low back pain or not with about 85% accuracy. You could tell us when you walked in the room, I've got chronic low back pain, so maybe that's not a very clinically important piece, but I think it's a good validation piece, right?
On that, so when you did the MRI scans, is there an overall accuracy predicted value of an MRI to predict chronic low back pain? And how would it compare to 83%? Because the numbers you showed would be way lower.
Right. So the short answer is I don't have that analysis, but it's not very good.
Right.
Yeah. But this is kind of, we can identify back pain. So cool, right? If you want to move from 83.7% to 85.2%, instead of just movement, pull in the 2 most other significant features, which were age and education level. Interesting, right? The education level part. But the age, definitely we can see, right? If you knew what age someone was and the way they moved, maybe you would know more carefully what they were experiencing. This, however, I thought was really cool. This is just saying, based on just the way they move, can we predict which level and whether they have disc degeneration at that level? So do they have disc degeneration at 1, 2, 2, 3, 3, 4, 4, 5, or 5, 1, based on just the way they move? And it turns out we're pretty good at it. Well, 67.2%. That's pretty good, right? And pretty good in terms of our sensitivity and specificity too. So this is 300 patients, so that's a relatively small number for a machine learning model, but still pretty good. And then what if we did it not just for disc degeneration, but we looked at modic changes and end plate changes, disc changes, facet changes, and stenosis, and could identify every one of those at the specific level it was happening, just based on the way you moved. We got an average overall accuracy of 70.6%. That's pretty good based on just the way you move. So, and an $8 piece of material in 15 minutes in the clinic. So, I'm actually ahead of time. This is good. MRI features of individuals with chronic low back pain and healthy cohorts are not dramatically different. Biomarkers have an accuracy rate of identifying the type and specific lumbar spinal level of MRI identified degeneration features of at least 70%. I think it'll get a lot better once we get even more subjects. So this is my question for you. How could those insights, or having a tool like this, how could that impact your practice?
Did you have they had more than one or two or three of those?
Did I have what?
It's like, did you have a number, like if they had multiple, is it sarcopenia?
Yeah, this is getting everything right.
So
That means I'm nailing exactly the level and where it had that, and if it had multiple, I'm getting multiple of them right.
it was just MRI, right?
This is just the correlation with MRI. Teaser, I'll share some of the cool phenotype-specific things that we do with tracking it back to all of the biopsychosocial aspects of pain, and that's like, this is our work of 6 years, and it actually tracks really, really well.
If there was a lot of fatty infiltration in one area, was there different characteristics of an MRI that say, well, they have facets and they have this, but then there's this level of fatty infiltration here, or this area?
We were not looking at fatty infiltration at all, which we should, of course. Let me ask you a question. Even if I have the whole world to draw from in terms of number of subjects, would you expect that it would be a one-to-one between the imaging and the movement?
You can go one-to-one.
I don't think it would be.
But I'm just saying, when you look at something,
Yeah.
when you go back to your first slide and somebody comes with chronic low back pain, there's a lot of compensating mechanisms going on once somebody has something, right? So something can happen and they may be changing for a little bit, and they still won't have back pain because the body's doing its job and it's trying to get it out of that position that's highly inhibited.
Yeah.
And so then it becomes more, now what's going on? So I'm just looking for that.
Yeah.
Fascinating.
There's some cool stuff that's missing here, right? One of them is the fatty infiltration and overall muscle quality, right?
Yeah.
None of that is here. But the other piece is really all of the psychosocial aspects of pain. None of them are represented here. And of course they're important, right? So that other 30%, we may get a little bump on that. I think we will from getting more subjects. But I think the other difference there is that just having the imaging actually doesn't tell me everything I need to know.
It's kind of interesting to have the cardiologist here.
Yeah.
And I'm just curious how putting the patient in motion and with a cardiac stress test has impacted cardiology, and if how you decide to order that and how do you use that information.
I mean, it's useful if the patient can walk on the treadmill and finish the treadmill protocol. They often can't. They think they can, but they can't. And I usually ask the patient, can you walk on a treadmill? If they say no, I don't even try. If they say they want to try it, we usually give them a shot. Probably 2 out of 3 finish the protocol. The other third have to get converted to a chemical stress test. Some of them haven't walked that far or that hard in a long time. They don't realize it, but they have to try to do it.
Yeah, I sometimes, if you see me walking a patient up and down, it's my test of how well they move. If they don't move well, then that'll lead to other testing. But if they move great, then it's like, okay, so I think you'll do well with surgery. So, or some sort of, orthopedic procedure.
Cool.
They just kind of, we see a patient, they come in and report symptoms, and maybe there's some physical exam findings, and then you're looking at imaging. But in the end, what is really the thing we're after is how are people moving, and what happens in real life when they move. And so it's almost like, this addition of testing or seeing how things respond to movement. It's interesting corollary. It's been missing, I guess, is one way to put it. I know that Ben talked about that the Ortho 9 had, a very simple way to test them, patients in clinic, by getting them up out of a chair and seeing how they respond, how quickly they can do it. There's just a very high yield, simple test in clinic. But this idea of capturing motion and quantifying and even getting precise with the analytics around it is pretty fascinating.
What's interesting to me is that any one feature from that is not enough. It really is this massive data thing. So even though some of you, and frankly, we have a really nice neural network in our heads, right? So some of you, especially with training, you can see this, but you're relying on this exceptional computer to interpret all this data. But sometimes having this objective kind of system can help us identify things that maybe we wouldn't catch otherwise. I'm going to add in this because I'm a professor and I'm an educator, and I think this is pretty cool. Beyond BYU, just to kind of give you a status on kind of what's been going on with this project. So we now have 1,300 spine sense arrays that have been built, these wearable sensor systems, completely by students at BYU. They've been used to collect spine biomechanics data over the past 5.5 years. We've had 1 postdoctoral fellow, 4 PhD students, 16 MS students, and over 100 undergraduate students that have participated in this project. And they come from departments all over BYU campus, 14 sites nationwide that have used this technology, including part of a major clinical trial, the BEST trial, that all the data from that will be coming out. The first papers are coming out at the end of this summer. Including a couple of patients at Summit. We hope to get more as we kind of move forward here. It's been used by over 40 clinicians and technicians. 4 additional clinical studies. That BEST trial, we studied muscle fatigue. We were able to identify with over 85% accuracy whether their paraspinal musculature was fatigued or not based on the way they moved. And then we've had collaborators all over, including UCSF, UPitt, Stanford, Harvard, OSU. And our next version of this is self-applicable. You don't have to have this stuck to your back now. You can zip it on, and it will include integrated surface EMG to kind of add the muscle activation to this. I'm pretty excited about where it's going. But hopefully it will end up in a tool that maybe some of you can use to get some quick objective data. I think it's really interesting that I know a couple weeks ago there was a discussion about PTs now becoming a primary care, a primary source. This is a tool that would work really well kind of in that setting. Anyway, thank you very much. I appreciate the questions at the time. Oh yeah.
Is that a vest then? I mean.
Oh yeah. It's more, well, the format is so right now we've looked at a version that kind of is a strap and you kind of zip on. We've also looked at one that's more of like a compression shirt, and both of those seem to be working really well at collecting data. So
I just found it interesting, the placement of the sensors, like you do the flanks, which is so important, and clear the shoulders, right? That it's not just symmetry.
Yeah.
Interesting.
Thank you. Yes.
I'm also curious about what were the psychosocial measures?
Oh, we actually had a really broad array of almost everything in the PROMIS category, plus some other, the PEG and some other ones as well. But happy to share kind of our data with you. But yeah, the team that was working on this, which is nationwide, part of this backpack consortium, includes a lot of folks who are on the psychosocial part of chronic pain, and so they were pretty rigid, pretty good at getting us all those metrics into all of the studies that were part of this consortium. So, yeah, thanks.
I think this really identifies the importance of working together as a team and everyone collaborating together, because there's so many components to all of this, right? These are great predictive values, but you even think about anxiety, depression, sleep, nutrition, like all of those things play a huge role. We like to look at these images and just say, yeah, that's the reason for your pain, but we're realizing like there's not a direct correlation. We got to look at what the pain is or what the actual pain is. And if the imaging matches it, it could potentially be that, but if they're sleep deprived, it could be that too, There's so many factors that we need to consider, and having a many minds approach is so crucial to helping these patients.
I agree. Thank you. Much appreciated. Any other questions? Comments?
So this seems to be primarily focused on diagnostic.
At this point, yeah.
And predicting, but I'm seeing the potential application of efficacy too. You put this on after a PT session. Are they moving differently put it on after surgery, has their motion improved?
Prophylactically, if you've got chronic low back pain, one of the things we interestingly saw was that many of our chronic low back pain patients, most of the time, have a fairly low level of pain. And then they have an element where they have get their paraspinal musculature fatigued. Their passive stability system is already gone. Their active stability system is now fatigued, and they're prone to a flare-up of a large amount of pain. So if we can prophylactically identify, now you're moving differently because you're fatigued, we could send them a push notification on their phone that says, stop. You need to sit down or you're going to trigger that. I think there's a lot of places we will be eventually able to go from an intervention, from a tracking, but having a tool, that's kind of the starting place. So thanks. All right. Thanks, everybody.